So this morning I'm going to be talking about screening for COPD, and please feel free if you want to ask questions at any time to raise your hand or yell out. If we just leave it to the end you might forget what the question was going to be, so I'm quite happy for you to do that. Well, I've got some bright lights in my eyes, so you might need to sort of jump up and wave a bit because it's a little bit hard for me to see out there. And here are some people with COPD trudging around Albert Park Lake this morning, all a bit puffy, wheezy, sneezy and so on. So I should just clarify what we mean by COPD initially. Obviously it stands for chronic obstructive pulmonary disease, and it has been called by other names in the past. So COAD, COLD, CAL, chronic airflow limitation, smoker's lung. They all mean exactly the same thing. It's that the modern terminology that we use these days is COPD. And it's really made up of two main diseases. One is the emphysema that occurs in the lungs, and the other one is when the airways themselves are narrowed down. And in individual patients, we can't really tell how much of each of those are there, so we just lump it all together and refer to it as COPD. So what is COPD? Well, it's a disease in which there's airflow obstruction in the lungs, so the airways are narrowed down, or with the emphysema, they collapse down very easily, so it makes it harder to get the air in, but even more so out of the lungs. It's a progressive disease, particularly while people keep smoking, so it just keeps getting worse and worse and worse. And also it cannot be cured, and it's not reversible, even with the best possible treatment that we can give patients over months and years. We're never able to get their lung function back to normal. So it's a permanent condition, and it just keeps getting worse. The airflow obstruction is due to two mechanisms. So one of them is that the cigarette smoke or the other irritants irritate the airways and produce an inflammatory response in the airways, so that you get thickening of the epithelium, there's edema there, there's increased mucus production, increase the number of cells in the airway wall. As well as that, the muscle layer in the airway wall becomes thickened, and that muscle is irritated, so it tends to contract down, which is why bronchodilators can be useful in COPD because they help that contracted muscle to relax. But there are also other permanent changes in the airways, increase in fibroblasts and collagen and other connective tissue in the walls, so that the airways themselves just become narrowed down. The second mechanism is the emphysema. So emphysema is loss or destruction of lung tissue. So that's the alveoli and the air sacs get destroyed in emphysema, but also there's a fine connective tissue and elastic tissue network throughout the lungs which supports the alveoli and also helps to support the airways, which are spreading throughout the lungs in a network. And not only do you lose the alveoli with emphysema, but also that connective tissue supporting network gets lost, and that connective tissue helps to support the airways, so that when the airways are less supported, they're floppy, so that as we breathe in, we can pull open our chests and open up the airways and allow the air to come in reasonably well. But when we breathe out and we compress the lungs to push the air out, the airways which are embedded within the lungs also get compressed a little. And in emphysema, because the airways have lost that support around them, they become floppy and get compressed down much more easily. So even though emphysema is not directly affecting the airways, by reducing that supporting structure around the airways and making the airways more floppy, the emphysema also leads to airflow obstruction as well. And most people with COPD will have a mixture of these two things. It varies from person to person how much of each is there, and as I said, we can't tell in clinical practice which one is which, so we just call it all COPD. And most of this is all caused by cigarette smoking. So in Australia, cigarette smoking is by far the commonest cause of COPD and these problems. All smokers will develop some degree of emphysema. So in the United States in the 70s, in Veteran Affairs patients, all of them had post-mortem examinations at death, and with histological sections, all the smokers were found to have some degree of emphysema. Now, of course, we don't do that in clinical practice. We don't do biopsies of the lungs to find the emphysema. But if you want to be able to tell your smoking patients that they're developing emphysema, then please feel free to do so without having to cross your fingers behind your back. About half of smokers will develop some degree of airflow obstruction, which we would measure with spirometry and other devices like the COPD-6. So roughly half of smoking patients will develop COPD. But if you go out into the community and just ask people, have you got COPD or emphysema or some sort of smoking-related disease? The language is difficult for patients, so when these sort of surveys are done, you have to use a wide range of terms so that patients understand what you're talking about. But in that sort of situation, what you find is that about 15 to 20% of smokers will say that they've got some sort of lung disease, whether it's emphysema, chronic bronchitis, or whatever related to smoking. So you can see that there's a fair gap between what we know of the percentage of patients that do have COPD and those who have actually been given a diagnosis by their healthcare professional. So there's a lot of COPD out in the community which is not recognised and not being diagnosed. We also know there's a problem particularly in people with asthma who smoke, because people who have asthma and smoke are more likely to develop COPD. So there are about 2 million Australians have COPD at the moment. It's the 6th commonest cause of death in men and the 7th in women. So it's a major health burden on the community. It costs nearly $9 billion due to hospital costs, healthcare costs, lost productivity and premature death. So it is a major health issue in Australia and also worldwide. That it's now becoming a major illness right around the world and overtaking things like infections and starvation and those type of things, even in poor countries. Because even though we have reduced smoking rates here, smoking rates in countries like China, Brazil and India are increasing, and so the prevalence of COPD is increasing in those countries. There's been a major study done all around the world called the BOLD study, which is looking at the epidemiology of COPD. And this has been done in Australia in several centres, including Sydney and also up in the Kimberley. And what they do with this study is go out into just randomly select people in the community off the electoral roll, people over 40, and carefully assess them to see if they have COPD. So this is just anybody off the electoral roll. They don't have to be smokers or have any illness. And they're carefully assessed with history and examination and also spirometry testing. So from that, we know that about 14% of people over 40 in Australia have COPD based on spirometry and history and examination. But only 17% of those in this BOLD study were given a diagnosis of COPD. So you can see that well over 80% of patients with COPD have not yet got the diagnosis. And that's where you come in, because we need screening of patients to be able to pick up those ones that are hidden. The other problem is that there are also patients who are labelled as having COPD, but in fact don't have it. And perhaps the assessment of them by their local doctor or even the hospital doctor has been somewhat cursory. Oh, you're a bit breathless, you're a smoker, you must have COPD. And when in fact they may not have COPD. So it does work both ways. But of course the biggest problem is the hidden COPD that's remaining undiagnosed. Here's another similar type of study looking at the prevalence of COPD in an epidemiological study, and you can see that the prevalence increases depending on the smoking history. So it's much higher in smokers compared to non-smokers or past smokers. And also, if you break it down according to age, you can also see that the prevalence increases. So in the different smoking groups, there's increasing prevalence with increasing age. And if you take people over 65 who are still smoking and you carefully assess them for COPD with spirometry or the COPD-6 or whatever, then you'll find about 40% of them have COPD. So if you're screening a group of patients like that, your pickup rate is actually quite high, which very much makes the screening process justifiable. The reason that a lot of this COPD is hidden is because COPD develops very slowly. It takes years and decades for the COPD to occur. And patients have trouble detecting this slow change. And maybe they used to walk 2 kilometres to the shops, but now they're tending to drive the car because, well, I'm in a bit of a hurry today, or today it's raining, it's a bit cold, I'm getting a bit puffed out by the time I get to the shops. Maybe I'll put on a bit of weight, I'm a bit unfit, I must do some exercise. So they make up all of these excuses about why they're now driving the car to the shops instead of walking. But really what's happening is they're developing COPD, getting breathless. They don't like that uncomfortable feeling of breathless, so alter their activities to avoid breathlessness. So one of the main symptoms of COPD is limiting activities, being less active. And if you ask people, do you ever get short of breath? Nope, never short of breath. Does that mean that that person is asymptomatic? Well, what about if you mow the lawns? I don't mow the lawns. Why not? Because I get too puffed out. So that person, even though they're not breathless, has a significant symptom, which is restriction of activity. But that's hard for clinicians to detect, and it's hard for patients to describe. And we know that if you then carefully assess patients with COPD about their breathlessness, that even though they do have some breathlessness, they don't think of it as a big issue because they get used to it. So MRC is the Medical Research Council in England, and they have a standardised way of assessing breathlessness. So grade 4 breathlessness is getting breathless, say, walking 100 metres. That's pretty significant dyspnea. But 60% of COPD patients with that level of breathlessness think that their disease is only mild or moderate. So they're not that fussed by it and don't come along complaining about it. And even grade 5 breathlessness, so that's getting breathless, having a shower, getting dressed, doing things like that. Only about a third of them still thought their disease was only mild. So you can see there's a real problem with people trying to estimate the severity of their disease themselves. Now, I know you're having breakfast and you perhaps don't want to see a patient while you're having breakfast, but just be thankful you're in the COPD session and not in the session about diarrhoea and vomiting and babies and things like that. I'm not putting up any pictures of vomiting and diarrhoea and so on. I'm a respiratory physician. I stick to the clean end of the body. But we would expect any nursing student, medical student or whatever to see someone like that and just know straight away this person has COPD. Look at the big barrel-shaped chest, the intercostal indrawing, Hoover's sign, the pursed lip breathing, accessory muscle use, muscle wasting, nicotine on the fingers. If you listened, you'd hear the prolonged expiration, maybe a bit of wheeze. I mean, that's a classic case of COPD, and you don't need spirometry to diagnose it in him. But of course, most patients with COPD don't look like that. Most patients with COPD have a normal physical examination. And again, this has been tested in clinical trials, so that if you carefully assess someone and you think that they have COPD, then you're going to be right. So the specificity of clinical assessment is 95%. But the sensitivity is only about 25%. So what that means is that you can only pick up on clinical grounds about 25% of COPD patients. The others, not because there's anything wrong with your clinical assessment, but you've just got no idea because their physical examination is normal and their symptoms are just too subtle or difficult for the patient to describe. So that gap can only be filled by doing spirometry or other similar measurements like COPD-6. And this is important. The French have done a study we're again just gone out into the community, not patients in particular. So nearly 5,000 workers over 45. Half of them have never smoked. Others, the other half were either current smokers or past smokers. They took out the asthmatics, because you might expect some airways disease there, and 7.5% of those had some airflow obstruction. Now, 94% were previously undiagnosed, so the similar sort of situation to Australia. 59% were mild COPD, but that means, of course, that over 40% were moderate or severe. 36% were moderate, which means 4% had severe COPD, like that fellow we just saw, and still not diagnosed. And this wasn't just numbers in a study. It actually had an impact on these patients. Those who did have airflow obstruction, in fact, were more short of breath, even though they weren't complaining about it, had a poorer quality of life, and were spending more time off work. So nearly 7 days a year compared to 1.5 in those without airflow obstruction. So it is important both for the patients and also for the general community in terms of lost productivity and so on. Because of this problem, in the United States now, the National Lung Health Education Program, which advises primary care doctors about how they should be managing patients, now recommend that GPs should perform spirometry in all smokers and in those who have quit in the last year. And what they're doing there is trying to identify COPD. Obviously, if there are any respiratory symptoms at all, cough, wheeze, breathlessness, activity limitation, they should also have some spirometry being done. And anyone that comes in just for a checkup, check my blood pressure, my cholesterol, whatever, spirometry should be a routine part of just a general health checkup as well. And whether that's with a spirometry or whether a handheld device that produces the FEV6, they're quite happy for that to happen. And the reason they recommend this is that if people aren't doing regular spirometry like this, then a lot of lung disease, particularly COPD, is going to go undetected. And when we do detect COPD, then there is a suite of treatments that we can provide these patients to help them out. So really the only way to get the diagnosis of COPD is with spirometry. It's a simple, easy, cheap, harmless test for patients to do. We get 2 measurements from the spirometry, the FEV1 and the vital capacity. So we ask the patients to take a really big breath in and just blow it out into the spirometer as hard and as fast as they can and get all of the air out into the spirometer. That gives us the vital capacity, which is the size of the biggest possible breath a patient can take. And we also measure how much comes out in the first second. So that's the forced expiratory volume in 1 second, or the FEV1. So that if a person's airways are narrowed down, it's going to take longer for the air to come out, so less air will come out in the first second. If a person has a restrictive disease, so they can't take a really big breath in, then there'll be less air in the lungs, so less air will also come out in the first second. So to distinguish between obstructed and restricted diseases, we take the ratio of FEV1 over vital capacity. So in other words, what proportion of the total amount of air comes out in the first second. And that ratio tells us whether someone is obstructed or not. Now some people like to give it a fancy name and call it FER, or forced expiratory ratio. But if that ratio is less than 0.7 or 70%, then that person has airflow obstruction. And if it's greater than 0.7, then they don't have airflow obstruction. So that 0.7 is a number worth remembering. It's not 100% correct, because older people it's a little bit lower, 0.69, 0.68, 0.67. In younger people it's a little bit higher, 0.71, 0.72, 0.73. The spirometer will often give you an age-adjusted cutoff, but sometimes you don't have that. So use 0.7, but just remember there's a little bit of a grey area in older and younger patients. So when you see spirometry results, it doesn't matter how it looks, whether it's on a little screen on the device itself, whether it's a printout from your own spirometer, from a respiratory lab or wherever, hunt around until you find the ratio, Look at the ratio. If it's less than 0.7, then that person has airflow obstruction. That's how we define airflow obstruction, so you can be quite definitive about it. If it's greater than 0.7, then they don't have airflow obstruction. Then have a look at the vital capacity. If the vital capacity is reduced with a normal ratio, then they've got a restricted problem. So a restricted problem is things like pulmonary fibrosis, respiratory muscle weakness with neurological diseases, or a chest wall disease where they've got kyphoscoliosis, stuff like that. And if the ratio is normal and the vital capacity is normal, then their spirometry is normal. So how easy is that? That's why I did respiratory medicine, because it's easy, a lot easier than ECGs and complicated things like that. It is useful. In primary care in the United Kingdom, a study was done where all smoking patients were given advice about smoking cessation, and they were randomised to having a discussion about their spirometry results or not having their spirometry results explained to them. So in those in whom they got the smoking cessation advice plus a discussion about their spirometry results, that doubled their smoking cessation rates. And because it's focusing the patient, everyone knows that smoking's bad for you, but if you make the effort to do a test and talk about the results with the patient, and then that focuses the patient, actually, this nurse or this doctor is concerned about my lungs enough to actually go and test them and talk to me about them. That helps motivate people to stop smoking. So there is justification, particularly in smokers, for doing spirometry and help increase smoking cessation rate. Smoking cessation is the only thing that slows down the accelerated decline in lung function. And this is the famous Fletcher and Peto graph that illustrates this. On the x-axis, we have age, and research studies have shown that the average person ages by 12 months every year. Come on, it's not that early. On the y-axis is your lung function as a percentage of what it was at 25. And here we're looking at FEV1. So for those of us in the room who are getting any older, and I do recognise that maybe some of the ladies are not getting any older, but for those of us who are getting older, you may notice that various bodily functions decline with age or things start to sag. Well, that includes the lungs. So we lose about 15 to 20 mil of FEV1 per year simply because of ageing. So that's no lung disease, no infections, no nothing. And that's what that green line represents. So that's just the normal age-related decline in lung function in completely normal people. So by the time you're well into your 70s, you're down to about 3/4 of the lung function you had from when you're in the 20s. Now that doesn't matter because we're built with extra lung capacity. If you could think of the hardest possible exercise you could ever do, you're only using about 70% of your maximum ventilatory capacity. And also, cardiac function declines with age. So the reason an older person can't do as much as he or she could do when younger is because of the loss of cardiac function. Now, in a smoker who develops COPD, their lung function goes down at a much faster rate, like this yellow line. Now, that's just a typical COPD patient. Another one might be more severe and go down much faster. Another one might be milder and go down more slowly. But that's the accelerated decline in lung function in COPD. If a person with COPD stops smoking, they'll still get a decline in their lung function because of the normal age-related decline, but it'll go back to that normal age-related decline. So they'll slow down that accelerated decline in lung function. So that's why smoking cessation is so critical. That's why it's important to diagnose COPD patients as early as possible in their disease process and to help them to get to stop smoking as quickly as possible. So thanks very much for listening this morning. Did anyone have any questions at all? No? All stunned? Everyone's got their mouth full? So thanks very much.